Hi everyone. Welcome to my functional knee anatomy presentation video. We're going to talk about functional knee anatomy. Okay, let's get to it. So there are bones and joints, obviously. So the most important bones is the femur, the tibia, the patella, and the fibula. Um, Mostly the fibula isn't super involved in the knee joint. It's on the lateral side, attached to the tibia. So it's kind of there, but it's not that important. So the femur is labeled at the top, the big bone, and then the tibia and the femur glide against each other. And then the patella is a sesamoid bone actually, which means that it's a bone developed in the tendon or a muscle. In this case, it's in the patella tendon. So it's not attached to like on a bone-to-bone contact, basically. And then joints. So there's three joints, two kind of more important joints that we're talking about with the knee anatomy. So the tibiofemoral joint, which is the tibia and the femur. That's actually the largest joint. And it's a hinge joint, so that means that it does like flexion extension. It does like this. I don't know if you can actually see me, but that's what it does. And then there's the patellofemoral joint, which is a joint, but not really a joint because it's on top of the tibiofemoral joint technically. But that's where the patella and the femur kind of attach to each other, but like not really. It's in the tendon. And so the patella moves, it helps like the patella to move up and down with the knee, like during flexion and extension. So it kind of glides doing that. With and then the tibiofibular joint, sorry, where the tibia and fibula attach on the side of the tibia. When it comes to injuries and stuff like that, the bones are really important, just because they're like the base of everything. So like with femur injuries, like femur fractures, tibia fractures, those can be a really big deal. Like they can, obviously immobilize you because they're such big like key factors in like weight balance, and like distributing your weight and like walking and running and daily activities. The patella can have a lot of issues. It's a common uh, due to like muscular tightness or weakness. So the patella, like if it doesn't sit correctly in the groove that is created on the femur, there can be a lot of pain with like friction and stuff like that. And so that's a big deal. And then with the tibia, it has like many, many, many different muscle attachments. And so that's also a common inflammation site because the overuse of muscles and different things like that. So inflammation is very common. So ligaments, we're going to talk about four very important ligaments. So the medial collateral ligament, MCL, lateral collateral ligament, anterior cruciate ligament, and posterior cruciate ligament. The MCL, they're all kind of labeled. So the MCL is obviously medial, so it's on the medial side, and then lateral is on the lateral side. The MCL is intra and extracapsular. And so it has like when it's injured, it can cause mild effusion, and that can be an issue. And then the LCL is just extracapsular. So the MCL limits the valgus forces, and the LCL limits varus forces. Those can be commonly injured just because, if you're hit from the side, usually the MCL and the LCL are the most common when that happens. And then the ACL and the PCL, so they actually cross each other on the inside, as you can see labeled in the middle. And so they help with knee stability front to back. And so when an injury happens to ACL or LCL, many times it results in surgery because of the stability that it keeps, and the lack of range of motion that can happen when there is an ACL or LCL injury, or PCL, sorry. And so the limited range of motion, especially with the PCL, the limited end range of motion can be really difficult because you're almost there, but you're not quite there. So that. The meniscus, or menisci, there's two. So the menisci, there's medial and lateral, as you can see kind of labeled there. These are labeled also with like different kind of tears, so that's kind of cool. You can see that. So the medial meniscus is C-shaped, excuse me. And it's actually attached also to the MCL. And so that it's also fixed. And so that means that it's like an increased likelihood of injury because it's fixed to the surface, so it doesn't give any when there's like rubbing. It basically acts as like it sits between the tibia and the femur, and so it acts as like functions for like shock absorption, stabilization, weight distribution, and then lubrication and nutrition for the area as it's written there. And so the medial meniscus is oftentimes injured more because it has an MCL attachment, and because it's fixed. The lateral LCL is like O-shaped, and so it isn't as fixed, and so like it gives more. So the likelihood of it tearing is decreased. You can actually get away with not having to have surgery with a meniscus tear. Some people don't. It doesn't affect some people. Some people have to get it taken out completely. That can cause problems in the future with, if there's nothing sitting there. It can cause more friction and bone problems with the bones rubbing against each other. So next we have muscles. So muscles, there's lots of muscles. So the quadriceps, there's the rectus femoris, vastus medialis, vastus lateralis, vastus intermedialis. And so those are all labeled up at the top. And then the hamstrings, the semitendinosus, semimembranosus, and the biceps femoris on the bottom. And then to the right, we have the popliteus. Yes. Hard word to say. And so the quadriceps, they help with knee extension. And so they're really important for like standing, walking, extending, obviously, like your foot out. And then the hamstrings are used for like knee flexion. And so that's important with like lifting your foot to walk, sitting down when you're like flexed, so that like if there's problems with your hamstrings, that can oftentimes cause issues because you're sitting in a flexed position for so long. And so when the muscles are injured, it doesn't just cause problems in the knee, but it can also cause problems, actively pain in other areas, because they can attach from the hip all the way like to the ankle practically. And so not attached to the ankle, sorry. But like they can affect the ankle because the weight distribution and all of like your whole body, because your legs are so important with carrying basically your whole body. And so when they are injured, different things can happen. Your range of motion is definitely limited. There's definitely pain. It can be harder to walk. It can be harder to stand, harder to run. It just kind of depends on what muscle it is, what the action was, how severe it is, different ratios of that, obviously. So, and then we have bursae or bursa and fat pads. And so there, I know there's a lot labeled there, but that was like the best picture I could find. And so the patella bursa, the prepatellar bursa, superficial infrapatellar bursa, deep infrapatellar bursa, the pes anserine bursa, and then the infrapatellar fat pad. And so basically, these are all kind of like, they just give like cushion basically, and they're there to give cushion and to hold the area, and that's kind of what they do. And so when injury to that happens, especially so like the bursae specifically, it can limit flexion because of swelling, and then it decreases the movement in your knee with injury to the bursae. And then with the infrapatellar fat pad, it can avoid extension because it can be swollen and it can be very inflamed. And so sometimes it can take longer to have that go down. Sometimes you'll have to stick like a really big needle and drain the fluid, because basically, or just like the fat pad is obviously fat, but like the bursae are like liquid, and so they're like squishy. And so when they get swollen and they get bigger and they're injured or they explode, all of that like liquid is in there. And so oftentimes if it doesn't go down in a couple weeks, you'll have to take a needle in there and take the liquid out so that you can obviously flex your knee, start walking better, be less swollen, and let it look less big. So um, that's all I have for functional knee anatomy. I hope y'all enjoyed my presentation, and I hope y'all have a great rest of your week. Thanks.